Good evening, everyone. It's a pleasure to welcome you for the IPNA endorsed Webmaster Series 2020. Today, we are having our fifth webinar, and it's spanning from September 12th to December 23rd. Today, we have two eminent speakers, Dr. Dechu Puliyanda and Dr. Nivedita from St. John's Medical College. Before we could enter into the topic, I'm just going to give you a brief outline of CKD in children. So the overview of CKD in children. So I would be covering on the definition, estimation of GFR, the epidemiology of chronic kidney disease in children, how is it progressing, the risk factors involved in it, and the few interventions we will be discussing on. So as per definition, chronic kidney disease refers to irreversible kidney damage with reduction of kidney function that continues to progress over time. And the KDIGO pediatric definition should fulfill one of the following clinical criteria with a GFR of less than 60 ml per minute per 1.73 meters square, which is persisting for more than 3 months with or without CKD markers, or if you have a GFR greater than 60 ml per minute, which is accompanied by evidence of structural damage in form of albuminuria, you can have urinary sediments, you can have electrolyte abnormalities, which is suggestive of tubular disorder, or you have an abnormal histopathology or imaging or history of kidney transplantation. And so the classification of pediatric CKD is based on GFR and albuminuria. We have 5 stages in it from G1 to G5, and G1 is normal GFR when you have more than 90 ml per minute per 1.73 meters square. G2 is between 60 to 89, and G3A is between 45 to 59, and G3B is between 30 to 44, and G4 is between 15 to 29, and G5 is when you have less than 15 ml per minute. And according to albuminuria, it has been staged into 3 things, which is A1, A2, and A3. A1 is when you have a normal or 2 mildly increased albumin in the urine, that is less than 30 mg per albumin per gram of creatinine. On A2 was moderately increased between 30 to 300, and A3 is severely increased when it is more than 300 mg per albumin per gram of creatinine. And we should always remember that in pediatric population, the urinary protein to creatinine ratio is much preferred than the albuminuria. It's because the common cause of pediatric CKD is congenital anomaly of the kidney, where detecting albuminuria alone may not detect the high levels of total protein loss due to tubular proteinuria. And for children who are less than 2 years of age, the above mentioned classification does not hold good because they normally have a very low GFR even when corrected for the body surface area. So you need to go according to the GFR, according to the serum creatinine, which is normalized for the age. And so we need to know the GFR estimation values, and for age, which is dependent on age and gender. For 1 week male and female, the mean GFR should be 40.6 plus or minus 14. Between 2 to 8 weeks for males and females, it should be 65 plus or minus 24. And we should note that more than 2 years of age, the GFR automatically reaches the adult values. And for 13 to 21 years, for male, it is slightly on higher side, which is 140 plus or minus 30. And for the same age group, for females, it is slightly lower, which is 126 plus or minus 22. So what are the general principles we need to take care when you are seeing a child with the chronic kidney disease? The first principle is we need to identify the risk factors, treat the reversible kidney dysfunction, prevent or slow the progression of CKD disease, treat the complication of chronic kidney disease, identify and adequately prepare the child and the family on the whole for the upcoming renal replacement therapy, and the timing of RRT completely depends on the severity of CKD. So depending on that, we need to have the primary prevention, secondary prevention, and tertiary prevention. For primary prevention, you need to identify the high-risk children. Who are the high-risk children? Children who have a family history of renal disease. If you have an antenatally detected renal anomalies, neonatal AKI, low birth weights, because they have a very low nephron number. When you have a history of UTI with reflex, any child with history of nephritic or nephrotic syndrome, renal rickets, hypertension, and prolonged use of NSAIDs, or all the children with high-risk categories. So these high-risk categories need to undergo a regular screening process. And next is secondary prevention. And so the goal of secondary prevention is basically slowing the CKD progression, either by you delay or defer the dialysis. The main thing is you need to have a tight control of the modifiable risk factors, that is hypertension, proteinuria. And next is tertiary prevention. The main goal of tertiary prevention is management of uremic symptoms and the comorbidities associated with the disease, like anemia, acidosis, AKI, mineral bone disorder, fluid overload. So we have already discussed the primary prevention is basically you have to identify the high risk group and make them on regular screening process. Secondary prevention is as soon as you identify, you have to treat them with appropriate drugs. And third is the uremia and fluid overload, where you have to manage them appropriately with pharmacotherapy. And once you diagnose a child as having chronic kidney disease, the first one, you fail the conservative management, the next step would be priming the child and the family on the whole for renal transplant. And we should always know that dialysis is only a bridge to renal transplant, and it is not the treatment for all CKD children. Next to the epidemiology of CKD, it is from a registry data. It has been noted that the North Americans, in North America, most of the 2 to 3 times increase in CKD are common in African American ancestor, and the chronic kidney disease in children. In a combined analysis of chronic kidney disease in children and a Neptune study, it has been noted out of 104 children with glomerular disease with high risk genotype experienced a faster decline in GFR when compared to the low risk genotype. It's probably because African American have a genotype of which takes them more prone for glomerular disease, and especially of more prone for FSGS. It's because they have a genotype of apolipoprotein L1. And next is age and sex distribution. Pediatric CKD is common throughout childhood, and it is more common in males, and it is a known fact that males have a higher risk because they have common anomalies like obstructive uropathy, renal dysplasia, prune belly syndrome. And we should note that during infancy and during the pubertal stage, they are more prone for worsening of CKD. It is because that is the time they have a rapid growth. So this rapid growth and sudden increase in body mass results in high filtration demand. And so moving on to the etiology, the common etiology is CACUD, which is the commonest, accounting for 24.4%. And the second commonest would be the primary glomerular disease, which is around 23%. And the cystic hereditary or congenital diseases, which accounts for 14.3%. And it should be very much noted, the miscellaneous cause accounts for almost 12.6% of CKD population. But all these data are from the studies taken from the good referral units. But in India, we have all underreported cases. And next is the progression of CKD. So any child who comes to you with chronic kidney disease and you identify as a glomerular cause, as a cause of CKD, with glomerular disease, you will have a significant nephron loss, which causes glomerular capillary hypertension, leading on to mechanical stretching. You have a mechanical stretching over the mesangial cells, endothelial cells, and podocytes. And podocyte stretching in turn causes increased angiotensin II synthesis, which causes disruption of cytoskeleton and causes loss of differentiation phenotype, leading on to food process effacement, cell diaphragm dysfunction, and increased permeability, leading on to proteinuria. So in children, CKD progression is so very much unpredictable. Few can reverse and few can have sequelae of CKD. So as already discussed, the progression of CKD is you have an intraglomerular hypertension, glomerular hypertrophy, which causes increased intraglomerular pressure, which results in systemic hypertension via glomerular specific process, which contributes to the glomerulomegaly. And finally, any child who's having CKD, if you biopsy them, you will have a histological finding of glomerular sclerosis, vascular sclerosis, tubulointerstitial fibrosis, which is referred to as secondary FSGS. And clinically, they would have proteinuria and loss of renal function. So whenever we see a child with chronic kidney disease, we need to have all these questions in our mind. We need to check what are the important risk factors associated with pediatric CKD progression. Are they modifiable? What genetic, familial, and ethnic predisposition influences the rate of renal decline? Are there any effective intervention that can slow down the progression of CKD in children? Are there biomarkers that can accurately monitor CKD progression? Are there any clinical tool that accurately predicts the rate of CKD progression to ESRD? So like you have the risk factors for CKD progression, you have modifiable and non-modifiable risk factors. The non-modifiable risk factors are age, gender, race, and the underlying primary disease, and particularly the glomerular disorders. And you have modifiable risk factors like hypertension, proteinuria, anemia, acidosis, dyslipidemia, hypovitaminosis D, and smoking if it is an adolescent child. So how is it underlying primary disease is related to chronic kidney disease? In a cohort study, it has been noted that glomerular disease had a greater annual decline in GFR than those of non-glomerular disease, which is around 4.3 versus 1.5 ml per minute per 1.73 meters square. And the progression of chronic kidney disease, if you see in glomerular disease, it is around 41% who requires renal replacement therapy, or they encounter a 50% decline in GFR, whereas non-glomerular disease is only 29%. And so the risk factors which are pertinent to glomerular disease and non-glomerular disease are, for glomerular disease, it is a urinary protein to creatinine ratio, which is more than 2 mg per milligram, and hypoalbuminemia when you have an elevated blood pressure. For non-glomerular, it's the same, the urinary protein to creatinine ratio of more than 2 mg per mg when you have hypoalbuminemia, elevated blood pressure, and on top of that, you have dyslipidemia, male gender, and anemia adding on to non-glomerular disease. So how is vitamin D deficiency related to progression of kidney disease? So in a multicentric European study, it has been noted that children with normal vitamin D levels had less proteinuria and slower decline in CKD progression than those with low vitamin D levels. So metabolic acidosis, children encounter overt acidosis when they have a decline in GFR of less than 30 ml per minute per 1.73 meters square. And when you have a metabolic acidosis, when your serum bicarbonate is less than 18 milliequivalents per liter, had a higher risk of CKD progression than with serum bicarbonate levels of more than 22 milliequivalents per liter. And genetic factors, as already discussed, the African American population has got the higher risk of CKD, probably because of the genotype involved, the apolipoprotein L1, which Sorry for the interruption. Am I audible?
Yes, to me.
So the tools to predict CKD progression is to how early we should refer them to renal replacement therapy. The clinical assessment tool is the progression of to ESRD is shorter with lower levels of estimated GFR, higher levels of proteinuria, and in children with glomerular disease versus those with non-glomerular disease. So the tool to predict CKD progression is they have come up with the kidney failure risk equation, which was actually developed for adults with CKD, but has got a good has a good value of prediction in children with CKD stage 3 and 4 as well. So in that study, they had enrolled around 603 children with CKID in a CKID study, and it had a few with a mean GFR of 44 ml per minute per 1.73 meters square, and it had a criteria of age, sex, and a GFR estimation, which is derived by Swartz formula, albumin to creatinine level, and calcium, phosphate, bicarbonate, and albumin. But the KFRE equation appears promising in pediatric CKD, but it requires further validation. So the potential biomarker would be soluble urokinase receptor has been identified as a novel risk factor for CKD progression in children. It is related that high SUPAR levels measured at baseline were more likely in patients who had a decreased GFR, that is 50% loss of renal function, 50% loss of renal function, and children who had to initiate on renal replacement therapy. In summary, I would like to conclude CKD refers to a state of irreversible kidney damage, reduction in kidney function, and the definition is based on KDIGO 2012 clinical practice guidelines, which says either you have less than 60 ml per 1.73 meters square of GFR, or if it is more than 60 ml, you should have other associated CKD markers like albuminuria, electrolyte disturbance, imaging abnormality, or abnormal histopathology. And the staging schema is based on GFR to classify severity of CKD. And GFR is equal to the sum of filtration rates in all the functioning nephrons. And in children, as already mentioned, for less than 2 years of age, the above classification will not fit in. So you need to have an estimated GFR based upon the serum creatinine value compared with the normative age appropriate values. And value more than one standard deviation below the mean should raise the concern and prompt more intensive monitoring. So in children, the incidence of CKD is always underreported due to asymptomatic nature of the early stage of CKD and due to limited resources to actually screen them. And congenital disease accounts for 60% of CKD in children, and second being the glomerular disease. And there lies a large knowledge gap in understanding pediatric CKD progression. Multicentric pediatric CKD trials have been established to improve our understanding of pediatric CKD progression and hopefully identify discoveries that can translate into therapeutic measures that can slow or either halt the CKD progression. Thank you. With this, I call upon the next speaker for the day, who's going to talk on anemia and CKD, the difficulties faced in maintaining goals. Dr. Dechu Puliyanda. She is afflicted to Cedars-Sinai Medical Center, California. Her special academic interest is CKD and its related comorbidities, renal transplantation, biomarkers, transplantation of highly sensitized patients. And her awards are Ben Cahan Award for Excellence in Teaching, Research and Patient Care in May 2019. Over to you, ma'am.
Hello. Thank you so much, Kalaivani, for that really nice introduction. Can people hear me?
Yeah, we can, ma'am.
Okay, great. A very good evening to all of you. Good morning for me here in Los Angeles. This seems to be a new wave of teaching that is happening, and I think that for the convenience sake, this might continue for the long haul. I have been asked to talk about anemia and CKD and difficulties faced in maintaining goals. I will be happy to take questions at the end. I'm not sure how the forum is in terms of questions, but I'm happy to even receive emails from participants in case there are any questions that will come up. There seems to be some background noise. I'm not sure if others need to switch off their audios. Okay, so we'll start with some objectives as always. Just for completion's sake, and I know this audience is pretty familiar, we talk about some definition, epidemiology. I think the crux of my talk will be on the causes of CKD. We'll talk a little bit about diagnostic testing and treatment and monitoring. But I'm also going to bring you up to speed on the emerging therapies for CKD and all of the clinical trials that are going on in pediatrics with respect to anemia management. Okay, so the WHO definition of anemia itself is when the hemoglobin concentration is less than 13 for adult males and postmenopausal women, because they expected to have a higher hemoglobin. It's hemoglobin less than 12 for premenopausal women. However, the WHO does not define goals for CKD patients, and so we have to refer to KDIGO guidelines that Dr. Kalaivani very nicely alluded to. So we also have to target a normal hemoglobin with erythropoietin stimulating agents, knowing full well that it increases the risks of adverse outcomes, especially cardiovascular outcomes. As you all know well, the prevalence of anemia worsens with worsening GFR. The stages of GFR were again very nicely alluded to by Dr. Kalaivani, but as you can see here, as a GFR worsens from 60 ml to less than 15 ml, the prevalence of anemia also increases, such that more than 3/4 of our patients, who are pre-dialysis or entering the dialysis realm, are significantly anemic. So the WHO also defines 8 specific hemoglobin thresholds for anemia in children. This is again from the KDIGO, and you can see that typically hemoglobin of less than 11 in the younger age group and less than 12 in the older age group, and for males less than 13 would qualify as anemia. This is probably the most important slide of all the slides that we have, is looking into the etiology of anemia and CKD, because if you remember the etiology of anemia and CKD, then you will not miss any of the risk factors for anemia, and you will pay attention and treat all of those risk factors. I'm going to take you back to what we learned in physiology as to what the etiology of anemia is. So it can be because of decreased production or because of increased destruction or loss. And if you look at increased production, decreased production, one of the important parts of making the red cells is to have all of the nutrition intact. So nutritional deficiency can give rise to anemia. So you have iron deficiency, folate deficiency, vitamin C deficiency, copper deficiency, and protein energy malnutrition. The other factors that can result in decreased production, especially in our CKD patients, is deficiency of erythropoietin or dysregulation of erythropoietin, which I'll bring you up to speed about. Also, a lot of inhibitors of erythropoiesis, like use of ACE inhibitors, hyperparathyroidism, because it makes for the bone marrow to be not conducive to make red cells. Inflammation is a huge factor in CKD patients, and we'll talk a lot more about it, the hepcidin upregulation pathway. In dialysis patients, use of a bioincompatible dialysate or membrane can also do that. What we know less about, but is also very important, is secondary carnitine deficiency can give rise to anemia, and in patients who are exposed to aluminum toxicity can give rise to anemia as well. If you look at the side of increased destruction, uremia, the uremic milieu makes for the red cells to not live as long, and so it decreases the lifespan of red blood cells, and therefore results in a rapid turnover of red blood cells. Hemodialysis and its associated blood loss can also result in anemia. Uremia can result in gastrointestinal blood loss, which really needs to be checked for all patients who are erythropoietin resistant. In the females, menstrual losses, and of course, the big portion of anemia in our CKD patients is the amount of blood draws that we do. So iatrogenic, iatrogenic anemia in CKD patients. Other causes would include, non-adherence with anemia therapies. Sometimes patients not wanting to take iron because it makes them constipated, and so on. Drug toxicity with a number of drugs, especially with the immunosuppressants like CellCept that we might use for patients who have nephrotic syndrome and so on. Other hemoglobinopathies that have to be remembered in like beta thal and sickle cell, etc. And a very rare condition called pure red cell aplasia that is associated with erythropoiesis stimulating agents, which I'll also be talking about real quickly. A little icebreaker here, we don't really give so much importance to the amount of blood that we draw from our pediatric patients. Remember, it's kind of the same amount of blood that's drawn in adults who have at least 2 to 3 times the blood volume of pediatrics. And so this is a very important cause of anemia in our patients. I'm not sure how, it is in India, but here we use what are called pediatric tubes to draw blood for pediatric patients, and we're constantly at a battle with the lab about drawing the least amount of blood for any given blood test. So why are we making such a big deal about anemia in children? There are a lot of consequences of children being anemic. It increases mortality. It increases the frequency of hospitalizations. And one important thing, again, going back to Dr. Kalaivani's talk, is it does accelerate decline of GFR. There have been a number of studies to show that. And so it is important to keep the hemoglobin in the right range. It increases the risk of left ventricular hypertrophy. Obviously, the heart is working harder when you're anemic. There's a greater limitation in physical functioning, exercise capacity, and schoolwork. Overall, decreased quality of life. And for the transplant world, it increases the risk of transfusions and therefore allosensitization. A little bit about erythropoietin, because it's so close to our hearts, with the kidney being so involved in red blood cell production. The EPO gene is on chromosome 7 and is responsible for the production of erythropoietin, which is a glycoprotein hormone. In utero and the newborn period, the liver is the most prominent place for making erythropoietin, but in the postnatal life, the kidney takes over and makes erythropoietin. This erythropoietin is a signaling molecule for the erythroid precursors because it binds to specific transmembrane receptors on the erythroblast and increases maturation to RBC formation. It is synthesized by the interstitial cells in the peritubular capillaries in the renal cortex. But the important thing to remember is that under conditions of injury, these cells transdifferentiate into myofibroblasts that synthesize collagen and lose their ability to make erythropoietin. So if you have a patient who's on the earlier stages of CKD, but who have significant anemia, it might mean that there's this injury going on to the renal cortex, and therefore even the few interstitial cells that are surviving are not able to make erythropoietin because they have transdifferentiated into myofibroblasts that are actually synthesizing collagen instead of erythropoietin. And then one of the other things to also know, and I'll come back to this when I talk about emerging therapies, is that there is a hypoxia-inducible factor 1, which is a transcription factor that regulates erythropoietin production through its binding to the hypoxia-responsible element on the EPO gene. So this also is very important in anemia in CKD, and we will talk about it later. So hypoxia actually increases the number of erythropoietin producing cells in the kidney. So if you look at this pictogram here, you'll see that under normal oxygen conditions, the kidney has a few cells in the interstitium that actually makes EPOgen, but under hypoxia, a lot more cells are geared up to actually make more erythropoietin. So the kidney response to hypoxia is to increase erythropoietin production. Another little cartoon here that shows that during anemia, there is low red blood cell concentration and therefore low oxygen carrying capacity of the blood and decreased tissue oxygenation. This stimulates the kidney to increase its secretion of erythropoietin, and in turn, the erythropoietin stimulates production of red blood cells and normalizes the low red blood cell concentration. It's a very important response that a normal kidney has in terms of regulating RBCs. Iron deficiency is another very important risk factor for anemia and CKD. There are 3 types of iron deficiencies. I'm not going to go into the gory details of it, but at least, just so you know, there's an absolute iron deficiency, which is multifactorial, where there is decreased nutritional intake of iron, poor enteral absorption, blood loss from the GI tract, menstruation in females, frequent phlebotomy and hemodialysis, where you have an absolute iron deficiency because you're not having enough iron to make red blood cells. But there's also a functional iron deficiency where there is enough iron, but it's depleted by the ESA-stimulated bone marrow. And then the third one is also very important in CKD, which is impaired iron trafficking in the setting of inflammation, where hepcidin comes into play. So, nice segue into hepcidin. I'm sure all of you have heard about it. It's a mediator of blocking iron, actually. So it's an iron regulatory protein that's produced by hepatocytes. Hepcidin is produced by hepatocytes. It's a key mediator of iron-restricted erythropoiesis in the setting of inflammation in CKD. And what it does is it prevents the use of absorbed or stored iron for erythropoiesis by the bone marrow. And its levels positively correlate with the serum ferritin levels, because as you know, serum ferritin is a marker of inflammation. So higher the serum ferritin levels, higher the hepcidin levels. We don't always measure hepcidin levels. So higher the hepcidin levels. One of the important knowledge that has come about more recently is that adequate vitamin D supplementation may reduce the hepcidin production, which is great, which is another reason why we need to keep the vitamin D levels normal in our CKD population. So again, another cartoon here to show you that the role of hepcidin in the regulation of erythropoiesis. So if you have a lot of inflammatory cytokines, it can block erythropoiesis by increasing the production of hepcidin. Hepcidin prevents iron incorporation into erythrocytes. The other thing that inflammatory cytokines do is they block the production of erythropoietin itself, which decreases erythropoiesis. The other mechanism is because of uremic toxins, which also decrease erythropoiesis. So hepcidin is sort of a key molecule in inflammation, which prevents iron being taken up by the red blood cells and therefore causes significant anemia. Okay. So going to diagnostic studies, what are the diagnostic studies that you would do in a patient with CKD who's having anemia? These are the simplest diagnostic studies that you can do, but please make sure you do this before you start them on any form of therapy. So you do a complete blood count, obviously, to see what the level of anemia is. Do an absolute reticulocyte count to see whether there's reticulocytosis that's happening or not. Check for serum ferritin and transferrin saturations. We'll talk about the KDOQ guidelines for that. And then also check and make sure that the serum B12 and folate levels are normal, especially in patients who are on hemodialysis, where a lot of the water-soluble vitamins are leached off with dialysis. Addressing treatment, ensure that all the etiologies of anemia are addressed prior to starting therapy with erythropoietin stimulating agents. I think the biggest difficulty faced in maintaining goals is not staying abreast with all the factors that cause anemia, and to jump ahead and start erythropoietin even before addressing iron, folate, and all of the other factors that I talked about. So just highlighting that's a very important thing for you to know. So pay attention to nutrition. A lot of these children who have uremia have decreased appetite, they're not eating enough, or they're not eating right. So make sure that your nutrition is adequate. They all need to see a dietitian to make sure that they're at least given supplementation with renal-friendly products in order to boost their nutrition. Iron supplementation is very important. The KDOKI guidelines tell us that you are iron deficient if your T-sats are less than 20% and your serum ferritin is less than 500. You can replete iron with either oral iron or IV iron. So oral iron is adequate in asymptomatic patients with just iron deficiency. When I say asymptomatic, it means that they have very mild anemia, or they are not anemic, but they are iron deficient, and so therefore will become anemic if you don't treat them with iron. And the commonly used preparations are ferrous sulfate, ferrous gluconate, and ferrous fumarate, and those have varying percentages of elemental iron in them. The dose typically that we use is 3 to 6 milligrams per kilogram per day, divided into 2 daily doses, with a max of about 650 milligrams of total iron that we would use. It ideally needs to be taken on an empty stomach for better absorption, or with some vitamin C, or we allow some orange juice if their potassium levels are okay to enhance the absorption. But one of the things to remember is to not take it with phosphate binders or with antacids, because it decreases the absorption. And in terms of monitoring, it's good to check the hemoglobin 4 weeks after starting therapy, and also check iron levels and sunscreen saturation about 4 weeks after starting therapy. Intravenous iron is another mode of giving iron, and the indications are if there's GI intolerance to oral iron, if there's severe malabsorption, when the rate of iron loss exceeds the rate at which iron can be absorbed. In patients who are on regular hemodialysis, they already are accessed, so you can give them intravenous iron. And in patients in whom T-sats are less than 10% and are not improving with oral iron, you may have to give them IV iron to boost the response. This is a quick slide comparing the parenteral iron preparation. I think, when I was much younger, I think the iron that we used always was iron dextran. And we all remember the time when we used to give a test dose of iron and then, give them iron, but being very, very careful, looking for hypertension and the risk for anaphylaxis. But since that time, the IV iron preparations have come a long way, and now the newer preparations, which I'll also be talking about, do not require a test dose, and can be given in a matter of 15 minutes and have a pretty long half-life compared to the older iron preparations. This is the preparation that we've been using. This is a more you can quit very fast. It's a bolus. It has a pH of 7 to 12 hours, which is kind of the longest of other iron preparations. This is ferric carboxy maltose, and it's also called by the trade name Injectafer. We give 2 doses, and we've seen a fantastic response in our CKD kids that is sustained for more than 6 months, and therefore kids who don't tolerate oral iron, this is a very good form of IV iron therapy. Moving on to erythropoietin stimulating agents. For the adults, it's recommended that if the iron saturations are fine, if the hemoglobin is less than 10 grams per deciliter, you start ESAs. But for children, we initiate based on the balance of the risk versus the potential benefit. So there isn't a specific start time, but usually we use the same threshold to start children on erythropoietin stimulating agents. The starting dose, as you know, is 35 to 50 units per kg, 1 to 3 times a week IV, or 150 units per kg, up to 150 units per kg once a week, even subcutaneously, which is more effective than IV iron. There is a long-acting analog called darbepoetin alpha, and that can be dosed weekly or every other week. We've used it in children. There have been studies that have been done that shows a very comparable value levels of erythropoietin alpha as well. The only, sort of an enhanced side effect of darbepoetin that has been reported is increased pain at the infection site, and so we've overcome that by using some lidocaine cream and such in order to be able to give these injections to the kid, and it's very well tolerated. So, and then when you adjust the ESA dose, it's better to decrease or change the frequency, but not necessarily hold the dose, because it's been shown that huge fluctuations in hemoglobin are not conducive to the child or to a patient. And therefore, it's better to decrease the dose or to change the frequency and not necessarily hold the dose. So let's talk about emerging therapies. This, for me, is sort of the really interesting part of the talk, because there are a lot of emerging therapies that should be in your armamentarium of care of kids with anemia and CKD. The first one is what I had alluded to a little before, called HRF1 stabilizers. It goes by the name of roxadustat. It's a small molecule HIF1 stabilizer, and it induces endogenous erythropoietin production, and it improves iron availability, and it reduces hepcidin. So it improves anemia by 3 separate ways. It increases endogenous erythropoietin production, it improves iron availability, and it reduces hepcidin, which reduces inflammation. So this is it's thought to be one of those breakthrough therapies for anemia. It was first received as global approval in China not too long ago, December 2018. The side effects are hyperkalemia and metabolic acidosis and pulmonary hypertension. To date, there are no pediatric trials that have even been started or ongoing, because we're still waiting for all of the adult literature to come out. But I can tell you that within the next year or so, Naprotix is thinking about being in one of the clinical trials for this drug. The other drug is antibodies against hepcidin or inflammation, with the use of monoclonal antibodies directed against hepcidin or at the inflammatory stimuli that increases production, including IL-6. So these anti-IL-6 therapies like tocilizumab or trastuzumab, which we are pretty familiar with in the transplant world, are being talked about as reducing hepcidin or inflammation, and therefore improving anemia. Again, there are no pediatric trials for this as well. The trials that are going to be there in pediatrics or are ongoing in pediatrics is this drug called Thera, which stands for Continuous Erythropoietin Receptor Activator. The drug itself is called Mircera, MIRCERA. It's an analog, EPO analog, that results in the extended half-life of 130 hours. You can just give it like once a month or twice a month. For these children, there's been a study that's been done on PD patients and has proven that it's safe and efficacious in maintaining hemoglobin levels. But there's an ongoing trial through Naprotix for children from 3 months to 17 years with this drug called Mircera. We should have the results in about a year, and hopefully then it's sort of FDA approved, and it can be used globally for maintaining hemoglobin concentration for anemia in CKD. I've put in a reference there for the one that's published, but the ongoing trial is, it's still ongoing, so we'll wait for the results. The other therapies is a drug called Ferric, which is a ferric pyrophosphate citrate. So that's why it's quite ferric. And it's administered via the dialysate. So this is a drug that's used in hemodialysis patients. So it can be administered via the dialysate, and you don't need to give it IV, you don't need to take it orally. And it's been shown to be extremely efficacious and safe in adults on hemodialysis. And the mode of iron delivery provides small amount of iron over hours compared to IV supplementation, which can help avoid oxidative toxicity. Again, there is an ongoing trial in children here through Napofix. It's for children of all ages, and it's on children who are on hemodialysis. One of the last therapies that I'm going to talk about is the use of ferric citrate. Ferric citrate is a novel phosphate binder that's available orally, but also supplies elemental iron, and it has the potential for decreasing phosphate levels with the phosphate binder plus an iron supplementation. So really, kills two birds with one stone, if you will. And there is an ongoing trial in children through Napofix too, for the use of this drug in our pediatric CKD patients. Lastly, a word on pure red cell aplasia. So there are a number of things that can cause a pure red cell aplasia. It can be a lot of times due to impurities in the erythropoietin that you're giving them itself. It could be because of improper storage and handling, and there are a lot of genetic factors that can also account for that. It's a very rare hematological disorder that was first described in the late 1990s, and it's characterized by severe and progressive normocytic anemia, reticulocytopenia, and almost a complete absence of erythroid precursors in the bone marrow, which with affected patients becoming very transfusion dependent. It's thought to be due to the development of neutralizing antibodies that block the interaction between erythropoietin and its receptor. And most initial cases were seen in countries where the erythropoietin was formulated with the type of a polysorbate stabilizer, and when it was administered subcu. Currently, there are no treatments for it because it completely blocks the receptor itself. So there's, there is no way of bypassing the receptor. However, it's been told that if you can try a different formulation of the erythropoietin stimulating agent, you might be able to overcome it somewhat, because the antibodies will be made to certain types of erythropoietin that you're giving and not others. So that's, again, we don't have good studies to show that, especially because it's a very rare disorder. And so, we just have to rely on some case reports. Sorry, this is a very busy slide, but I just wanted to throw this in. This is a reference to you for the KDIGO guidelines on the management of anemia in different stages of CKD, and this can be easily obtained as the KDIGO for pediatric. So quickly talking about treatment-resistant anemia and erythropoietin hyporesponsiveness is when there's no increase in hemoglobin concentration from baseline after 1 month of appropriate weight-based dosing. And the most likely it's associated with inflammation, very high rates of inflammation, fluid retention, which causes dilution and anemia, and hyperparathyroidism, which makes the bone marrow not conducive to make red blood cells, and therefore these three need to be addressed when you see that the patient is erythropoietin hyporesponsive. Also look for other factors that you haven't thought about previously, like we alluded to secondary carnitine deficiency, aluminum toxicity, protein energy malnutrition, and any of the concomitant drugs that you're using that might inhibit erythropoiesis. So to conclude, anemia is a very common problem in children with CKD, and the causes are multifactorial. It's not always erythropoietin deficiency, it's multifactorial, but mostly related to decreased RBC production, impaired erythropoietin production, and hepcidin-mediated iron-restricted erythropoiesis. Inflammation plays a huge role in anemia of CKD, and there are no well-defined goals for starting erythropoietin therapy, but we usually follow adult goals, which is hemoglobin of less than 10. One important thing is to make sure that all factors causing anemia are accounted for prior to starting erythropoietin therapy. Otherwise, you'll be giving a very expensive therapy in someone who's iron deficient and in whom it will not work. And so just taking care of those factors are important. And of course, to treat anemia aggressively to avoid blood transfusions is also very important. I'm quite excited about the new therapies that are on the horizon in various phases of clinical trials for children, specifically for children with anemia in CKD. And so we all have to stay tuned for the results of all such trials. And I think with that, I'll stop. And I don't know if I have time for questions, or if people can email me with questions. I don't know how this works, but over to Kalaivani. And thank you for giving me this opportunity to be virtually with you all today.
Thank you so much, ma'am. It was an excellent talk dealing all about anemia and CKD. Thank you so much, ma'am. Next speaker for the day is Dr. Nivedita Kamath. Dr. Nivedita Kamath is Assistant Professor, Department of Pediatric Nephrology at St. John's Medical College, Bangalore. Her special area of interest is chronic kidney disease, chronic dialysis, neonatal AKI. She is involved in committees. She is a honorary faculty of Kasturba Medical College, Mangalore. She is a member of ISPN Bulletin Editorial Board, Indian Society of Pediatric Nephrology. She is a member of Committee for Low Resource Income Countries. Over to Dr. Nivedita. Nivedita ma'am, are you there? Nivedita ma'am?
Are you able to hear me? Dr. Kalai, can you hear me? Can you hear me now?
I can hear you, Nivedita.
Yeah, okay. So let me begin. Thank you, Dr. Kalai and Dr. Namalvar sir and the entire team from Meta for organizing this IPNA webmaster series and for giving me this opportunity to be a part of this. I'll start with going from what is known about the pathophysiology and management of chronic kidney disease, mineral bone disorders, to what is new. In the next few minutes, we'll be looking at what is chronic kidney disease, mineral bone disorder. And we know that it is now described by the KDIGO Guidelines 2017 as a combination of laboratory abnormalities that mainly encompass the abnormalities of calcium, phosphate, parathyroid, and vitamin D. The bone abnormalities that constitute a wide spectrum of clinical abnormalities like renal osteodystrophy, growth retardation, muscle involvement in the terms of proximal myopathy, and also fractures, and vessel involvement in terms of calcification of large and small vessels, skin involvement, and keratitis and corneal calcification, and with devastating consequences like cardiovascular disease, fractures, and also mortality. So let's look at what the spectrum of chronic kidney disease, mineral bone disorder is in using the example of one of our patients who was diagnosed to have end-stage kidney disease at the age of about 6 months due to primary hyperoxaluria type 1 and initiated on CAPD. By about 4 years, she presented to us with hypocalcemic tetany, bone deformities, with a very high parathyroid levels and vitamin D deficiency. On treatment, she subsequently went to the other end of the spectrum, developing hypercalcemia, low PTH with normal 25 hydroxy D levels. and later on in her course developed multiple episodes of bone pains and fractures. And you can see her X-ray, which shows poor bone quality in terms of osteopenia with deformities and a malunited fracture and an active fracture on the neck of the femur. This was following a trivial trauma. So you may be able to see the entire spectrum of mineral bone disease during the course of one patient's, especially those who are in end-stage kidney disease and on dialysis. So what really is the burden of CKD MBD in children? And the IPPN registry of pediatric peritoneal dialysis says that clinical and radiological features of mineral bone disease can be seen in about 15% of children on peritoneal dialysis. The CKID study said that fractures are seen in about 12.5% of non-dialysis CKD. Vitamin D deficiency is seen in about a third. Low GFR, low calcium, vitamin D deficiency, and high FGF23 are important predictors of PTH. And from our own data, we found that about a third of our patients were hyperphosphatemic, about half of them had hypoparathyroidism, and almost everybody had vitamin D deficiency. The consequences of CKD that we see in children, This is a study, a slightly older study, but it gives the entire spectrum of manifestations with height less than -2 standard deviation or short stature being one of the most common manifestations of chronic kidney disease with mineral bone disorder. Clinical manifestations of bone disease in about a third of patients, pathological fractures in about 13%, and invalidating bone disease in 17.8% of patients. The fracture risk, which we saw in the CKID study, was 2 to 3 times that of the general population. Tanner stage of 4 and above, EGFR less than 60, difficulty in walking, and parathyroid levels were the most common risk factors. The only protective risk factor was the presence of a phosphate binder, and more than 80% of these children were on calcium-based phosphate binders. Mortality is a very important hard outcome of children with chronic kidney disease with severe mineral bone disorder, and the most common cause for mortality in children that we know from this very popular slide is cardiovascular disease. In children on hemodialysis, peritoneal dialysis, it is the most common cause of mortality, and in children post-transplantation, it is the second most common cause of mortality. And the risk factors of mineral bone disease that have been proven in adult studies and a few pediatric studies to be associated with mortality are high phosphate levels, vascular calcification, and high FGF23 levels. Going back to the basics, we know that mineral bone disease is basically an interplay of these 3 major factors: FGF-Klotho complex, 1,25-dihydroxy D3, and parathormone levels. And these have a mutual feedback regulation, and the main goal of these 3 hormones is to maintain the calcium and phosphate balance. And these are also the most important indicators that we look at when we clinically assess mineral bone disease. Coming to the trade-off hypothesis and what do we know now? So the trade-off hypothesis was put forth a couple of decades ago, in which it was said that the low GFR causes an increase in phosphate, which in turn stimulates PTH secretion, and the high PTH was then a trade-off that was acceptable for maintaining the phosphate levels within normal range. But now there has been a paradigm shift in the last few years, and FGF23 has emerged as the initial triggering event, which is raised very early in CKD, even in the presence of a normal phosphate, and that is the major trigger for causing hypoparathyroidism and decrease in active vitamin D. And this paradigm shift has then triggered off a cascade of events that we will come to later. So FGF23 and its transmembrane cofactor alpha-Klotho is important for its reaction on the FGF receptor 1C. FGF23 can also act through soluble Klotho, inducible Klotho, or Klotho-independent mechanisms. It's secreted as an hormone by the osteocytes, and it acts at the distal nephron and the parathyroid gland. At the level of the kidney, it causes phosphaturia and inhibits the action of 1-alpha hydroxylase. At the level of the parathyroid gland, it inhibits the release of parathormone. The exact mechanism by which FGF23 along with Klotho, which is present in the distal nephron, acts on the NEPI2A receptors, which are important for phosphate reabsorption, and the 1-alpha hydroxylase in the proximal tubule are not yet known, but this is an area that is being studied actively. Like we said, FGF23 has been found in several adult studies to be increased very early in CKD, almost as early as CKD stage 2, when there is no other evidence of mineral bone disease. And it is unequivocally associated with mortality, left ventricular hypertrophy and reduced vasodilatation, inflammation, and of late also with anemia of chronic kidney disease. Klotho, as we just saw, is a transmembrane protein that is responsible for the action of FGF on its receptor. The levels of Klotho are found to be decreased in CKD. Klotho also perhaps has an inhibitory role on vascular calcification and a protective effect against vascular calcification. Chronic high FGF23 is associated with a reduced Klotho production, and over the course of CKD, it probably causes something like a FGF23 resistance at the level of the parathyroid gland. Other new factors that have been coming in the forefront are magnesium, which has an important role in acting on the endothelial cells. It inhibits the vascular smooth muscle cell differentiation and apoptosis, enhances the production of matrix GLA protein and the osteopontin, which are important for inhibiting calcification at the level of the vessels, and also reduces PTH levels. So it has multiple effects on the bone, on the vasculature, as well as on the heart. The most important paradigm shift that has occurred in the understanding of mineral bone disease is that the role of the bone, which has moved from being an innocent victim to a major villain in the pathogenesis of mineral bone disease. We know that mineral bone disease is a complex interplay of multiple pathogenetic factors, including several biochemical abnormalities that we just discussed, treatment options like calcitriol, etc., other comorbidities that are associated with CKD like malnutrition, and also the native kidney disease itself, like we saw in our child with primary hyperoxaluria. And they have a bearing on this delicate balance between bone formation and bone resorption that is occurring as a physiological process in the bone. To understand this, we need to look at the spectrum of bone disease, which can vary from mild hypoparathyroidism to the other end of the spectrum of adynamic bone disease, and is measured in terms of volume, turnover, and mineralization on a bone biopsy. The osteocyte is the new protagonist, and it produces two important hormones, the FGF23 and sclerostin, which are now emerging as the key players in the pathogenesis of mineral bone disorder in CKD. To understand more about the pathogenesis of what happens exactly in the bone, we need to understand the functional unit of the bone. We know that the osteocyte, which was thus far thought to be a very dormant cell, is a key player. In addition to the osteoblasts, which are bone-forming cells, and the osteoclasts, which are bone-resorbing cells. Under the influence of PTH, the osteoblasts release rankle, which binds to the rank receptor, which is present on the osteoclast precursors, and activates them to form the active osteoclast, which causes bone resorption. The osteocyte, in order to balance this bone resorption, produces osteoprotegrin, or OPG, which binds to rankle and prevents it from binding and activating the osteoclast precursors, hence limiting bone resorption. The other important signaling pathway that has been discovered in the bone vascular crosslink or crosstalk is the Wnt signaling pathway. And this is pathogenetically, the counterpart is the bone vascular calcification paradox. So the Wnt signaling pathway is present in the osteoblast, and it increases the production of osteoprotegrin, which in turn inhibits bone resorption. And by some unknown signaling mechanism, the osteoblasts also increase bone formation. So the Wnt signaling pathway is a key pathway for activation of osteoblasts and inhibition of osteoclasts. In in CKD, there is a significant increase in Wnt inhibitors, and the most important of these that has been now the talk of the recent papers is sclerostin. Sclerostin, the new kid on the block, is a physiological regulator of the Wnt pathway and inhibits OPG, the Rankel system, thereby suppressing osteoblast activity and reducing bone turnover. Needless to say, it is important that the pathogenesis of adynamic bone disease. It also increases FGF23 secretion and inhibits the active vitamin D. It's increased very early in CKD, and this is again a paradigm shift that is probably going to be studied in more detail in future. But what is now said is that sclerostin probably increases earlier than FGF23. So is it the new initiating factor or the triggering event? We know that by inhibiting the Wnt signaling in the bone, it causes a low bone turnover. But what exactly happens by inhibiting Wnt signaling in the vasculature is not very well known. It has a negative correlation with PTH and bone turnover. It correlates well with the GFR and the efficacy of dialysis. It has a PTH-independent regulation by high phosphate itself and is the key factor in adynamic bone disease. Whether it reduces vascular calcification will probably be answered in the next few years. A little bit on adynamic bone disease while we are dwelling on sclerostin. Initially thought to be occurring late in CKD in patients on dialysis in elderly, those are on treatment with calcium and vitamin D. It is now increasingly being found in early stages of CKD, and high sclerostin levels are implicated in the pathogenesis of adynamic bone disease, along with uremic toxins and gut dysbiosis. Another important player that has been emerging to have an important role in chronic kidney disease is activin, which is produced by the kidney and the bone. Not only does it have a role in mineral bone disease, but also in causing renal fibrosis and progression of CKD. It has an effect of causing PTH-independent osteoclast stimulation and FGF-independent cardiac hypertrophy. Calciprotein granules or particles are the newest discovery that have been published recently in KI, where they are supposed to be the colloidal complexes of calcium phosphate along with fetchwin, which then acts on the osteocytes and releases FGF23. So they are touted to be the new bone phosphate sensors, and this is how bone senses phosphate and releases FGF23. The gut-kidney axis is a hot topic in chronic kidney disease, and CKD mineral bone disease is not spared from this. The gut dysbiosis occurs in the form of increased products of protein fermentation, like the pyricyl sulfate and the indoxyl sulfates. There is a reduction in the protective carbohydrate fermentation products, like the short-chain fatty acids, and vitamin K deficiency due to several reasons occur in chronic kidney disease. Along with this, there is a leaky gut, which results in the absorption of endotoxins, which have a pro-inflammatory role. All these have implications on mineral bone disorders. Another important concept is that of the bone marrow niche, which is a microenvironment of osteoblastic cells or the bone precursor cells and the vascular precursor cells. And this is regulated tightly by PTH, FGF, vitamin D, and Wnt signaling, and is now thought to be the micro hub where mineral bone disease actually starts. Inflammatory cytokines have an important role in causing the dysregulation of this bone marrow niche. Coming to the vasculature, is it just an innocent bystander that is taken over by this deluge of abnormal biochemical parameters that is happening in the circulation? The two major mechanisms that are occurring in the vasculature is the osteochondrogenic transformation of the vascular smooth muscle cells and an imbalance between the promoters and inhibitors of vascular calcification. We've discussed most of these, so I'll just go to the next slide. Again, sclerostin, which is still being studied and the role is not yet implicated well. Clotho, along with PTH, are important in causing vascular disease in CKD. The bone vessel link has opened up new avenues for research in both adults and pediatrics. In adults, it has been shown quite well that demineralization of the bone is associated with calcification of the vessels. So worse the bone, worse the vessels. However, this is not so simple in children with CKD, where perhaps better the bone, worse the vessels is the hypothesis. A cross-sectional study of the 4C study showed that in 32 patients pre-dialysis CKD showed that greater the trabecular thickness and density, higher the diastolic mean blood pressure. And the major determinants of blood pressure were serum calcium and trabecular thickness. So this is something of interest to all of us. To summarize what we just discussed, the evolution of MBD, in the early stages, there is an increase in uremic toxins, FGF23, sclerostin, PTH, and phosphate, and a decline in active vitamin D and clotho, which in the initial stages leads to a low bone turnover, and in the later stages to a high bone turnover. The bone disease spectrum in early CKD is mainly the osteocyte is the culprit here, producing Wnt inhibitors, which result in a qualitative bone loss. And as it progresses, there are several factors along with the progression of CKD that add on, including the biochemical parameters, the treatment parameters, which result either in a low PTH or a high PTH state, resulting in a low bone turnover or a high bone turnover disease, and a qualitative and quantitative loss of bone. And simultaneously, there is increasing vascular calcification that is noticed at both ends of the spectrum. Coming to evaluation, there are several bone biomarkers, but they have mainly been reserved in the research arena and have not yet translated to clinical practice. They can be biomarkers for bone formation, for bone resorption, or osteocyte markers. And in children, only PTH and bone-specific alkaline phosphatase have shown some correlation with bone histomorphometry, but this again is not very consistent. So none of them have been really translated for use into clinical practice. Bone imaging there are several modalities that are coming up of late and mainly studied significantly in adults. We note that DEXA can be used for children with CKD, making sure that we know what the disadvantages of it are. Peripheral quantitative CT is a very important modality that is coming forth in several studies in adults and also in children. This particular study in children showed that high PTH levels, more than the recommended for this stage of CKD, was associated with a higher trabecular bone mineral density and a lower cortical bone mineral density. So that is the major advantage of QCT, which can differentiate between the trabecular and the cortical bone as opposed to DEXA. The cortical bone mineral density scores correlated with GFR and the duration of CKD. And for every standard deviation decrease in the cortical BMD scores, there was a 1.75 times increase in risk of fractures. High resolution PQCT studies are ongoing. MRI is also another important modality that is coming up, especially the high resolution MRI, where the delineation of bone microstructure is so good that it could be probably replacing the biopsy itself. However, there aren't too many studies even in adults. Another important imaging modality that is being explored in adults is quantitative bone ultrasound, which probably reduces the risk of radiation, and there are studies that are ongoing for its use in adults with CKD-MBD. Bone biopsy still remains the gold standard, and the KDIGO guidelines say it is reasonable to perform a bone biopsy if the knowledge of the type of ROD will impact treatment decisions. Coming to the management of CKD and going beyond the KDIGO guidelines, the main aim of the KDIGO guidelines is target high phosphate and maintain calcium, treat abnormal PTH, and give supportive therapy for bone calcification and growth. The KDIGO guidelines in children recommend the use of calcium-based phosphate binders in addition to other phosphate-lowering therapies like drugs, dialysis, and diet. The intestinal absorption of phosphate, we know the list of the usual phosphate binders that we use. What is new in this is the use of nicotinic acid, which reduces intestinal phosphate by downregulating its receptor, but it's associated with significant amount of side effects. Tenapanor inhibits the NHE3 and the paracellular transport of phosphate. The new pan-phosphate inhibitor EOS 789 looks more promising because it inhibits all modalities of phosphate absorption in the gut. Phosphate binders, Dr. Dechu has already discussed a little bit of ferric citrate. There's another iron-based binder, sucroferric oxyhydroxide. Both of them are shown to be non-inferior or equivalent to sevelamer. The advantage of ferric citrate, or the desirable side effect, is that it also increases the iron levels and reduces EPO requirements. And studies in children, there is a retrospective study, but studies are ongoing on the use of ferric citrate in children. The recent Pediatric Nutrition Task Force guidelines give us goals on dietary management of calcium and phosphate. The next important goal is controlling the PTH levels, and unlike adults, in children, calcitriol and vitamin D analogs may be considered in case of refractory hypoparathyroidism when all other measures have been used. Though there isn't a strong recommendation by the KDIGO guidelines, there are a lot of studies coming up on the use of calcium mimetics in children. So in our armamentarium for children with secondary hypoparathyroidism, we have vitamin D, active vitamin D analogs, and calcium mimetics. The recent guidelines by the European Society of Pediatric Nephrology recommend maintaining normal levels of vitamin D, either by using ergocalciferol or cholecalciferol. And though there aren't several like strong recommendations or evidence, the guidelines recommend this treatment. Coming to active vitamin D, both calcitriol as well as vitamin D analogs are recommended in secondary hypoparathyroidism that is refractory to the first line of treatment in children. Coming to the vitamin D analogs that have been studied in children, doxycalciferol and paricalcitol are the two major drugs which have been compared to calcitriol and are found to have an equivalent reduction in PTH. So, a few studies which looked at native versus active vitamin D showed that both are equally effective in reducing PTH. However, in general, vitamin D analogs are at risk of causing hypercalcemia, hyperphosphatemia, and an increase in FGF23, all of which are undesirable side effects in a child with mineral bone disorder. Coming to the calcium mimetics, considered the first line therapy in adults on dialysis with refractory secondary hypoparathyroidism, and there are more and more studies coming up in children as well. A systematic review published recently in Pediatric Nephrology showed that cinacalcet is safe and efficacious in reducing PTH levels to more than 30% from baseline. It's also effective in young children and infants, and also was associated with a significant amount increase in growth. The recent guidelines by the ESPN on cinacalcet use in pediatric dialysis has been published. Newer calcium mimetics in the pipeline are etelcalcetide, which has been studied in adults and found to be better than cinacalcet. The only disadvantage probably is that it needs to be given IV and can be used only in patients on hemodialysis. It causes a significant reduction in PTH. There are ongoing trials in children and trials to evaluate hard outcomes like cardiovascular disease and mortality. Evocalcet is similar to cinacalcet but has a better GI side effect profile, and there are some studies in adults to show its efficacy. Bisphosphonates are rarely used in children, and the KDIGO guidelines recommend them in patients with CKD, especially elderly with osteoporosis, with glucocorticoid-induced osteoporosis and hypercalcemia. There is not much data on its use in children, but zolandronate and ibandronate are the ones with minimal nephrotoxicity. Can we prevent vascular calcification by using any therapies? Some of the potential therapies in the pipeline are the role of magnesium, which we've already discussed. Vitamin K studies are ongoing because it's required for the carboxylation of inhibitors of vascular calcification. Mineralocorticoid receptor antagonists, but the obvious side effect, of course, is hyperkalemia. Crystallization inhibitors, which prevent calcification of the vessels, and ligand traps for activin and bone morphogenetic proteins. Some biological pipelines in the pipeline, these are again extrapolated from use in osteoporosis in adults. Denosumab, which binds to rankle and reduces osteoclast activation, and romosozumab, which is probably having promising results in osteoporosis and may find a role in CKD because it inhibits sclerostin and may be used in the treatment of adynamic bone disease, are the new biologicals to look out for. To summarize, we know that mineral bone disease is a complex interplay between the bone, the parathyroid gland, and the kidney, with significant side effects on the bone, on the heart and the vessels. FGF23 and sclerostin are the new players that are emerging as significant of significant importance in the pathophysiology and also as potential therapeutic targets. The osteocyte in the bone is a key player and is the protagonist of this saga. The vascular connection with bone disease has been well established in adults, but may be different in children, and more research needs to be done to establish that. Calcium mimetics are finding more evidence for use in children with refractory hypoparathyroidism. But unfortunately, despite all this research that is ongoing, the target levels of phosphate and parathyroid, which we need to aim for in clinical practice, are still elusive, and there is very few studies looking at hard outcomes with regard to phosphate levels and PTH levels in children. Thank you.
Thank you, Dr. Nivedita, for taking us through the newer concepts of metabolic bone disease. Thank you so much. Can we take up the questions now?
Sure.
So the first question is, what is the association between proton pump inhibitor usage for GERD in early infancy for prolonged periods, 3 to 4 months, and CKD? Dechu ma'am, are you able to hear me? Can you take up this question or? Can I read out the question again? Can I read the question again, ma'am? Nivedita ma'am, are you there?
Yeah.
Like, are you willing to take up the question, ma'am? What is the association?
Yeah, sure. Can you please repeat? Yeah.
What is the association between proton pump inhibitor usage for GERD in early infancy for prolonged periods, that is 3 to 4 months, and CKD?
So, if I'm getting the question right, is it proton pump inhibitors in a normal child causing CKD?
Yeah, that is what the question means. A prolonged period of 3 to 4 months, does it cause a CKD?
Proton pump inhibitors have definitely been associated with chronic tubulointerstitial nephritis, which can result in CKD in adults. There are several studies which show this unequivocally, and also not associated with progression of CKD. As far as I know, there are no studies in children, in the sense in normal children with only GERD, where proton pump inhibitors have resulted in chronic kidney disease. And I don't think it's even the thing in adults is, usage for 2 or 3 months, but a much longer usage over years. So I don't think there is any data to say that it can happen. I would not worry too much about it, but probably monitor these children.
Okay, fine. So it causes chronic interstitial nephritis. There is no cutoff months, either 3 months
very
or 4.
well known. It's a very well known cause of CKD, and there are a lot of studies that have come out, but not in children and not in otherwise normal children.
Okay. The next question is, I think Dr. Dechu can take up this question. What is the dose of Misra?
Yes, can you hear me?
Yeah, I'm able to hear you, ma'am.
Okay, great.
What is the dose of Misra?
Sorry. Mircera, the dose is still being established in the pediatric population. So we still don't have, we are actually starting out with lower doses and gradually titrating to keep the hemoglobin concentration, in the range 10 to 13 hemoglobin. So we really don't have a dose defined for pediatrics yet, but stay tuned. It should be coming out soon.
Okay. So next question is to Dr. Dechu. How ACE inhibitors can cause anemia and CKD?
Very nice question. So ACE inhibitors are thought to inhibit erythropoietin production by their effect on interstitial cells. And that's how it causes anemia. You've seen it, when you escalate dose of ACE inhibition, these patients actually have, progressive anemia. It's again because of inhibition of the interstitial cells, which is another effect of the ACE inhibition.
Okay. So the next question is, are you using oral ferric citrate?
Are we using ferric citrate?
Yeah, oral ferric citrate.
Yes, we are using oral ferric citrate in our adolescent population because they are more or less, quote, young adults. We are using it in patients who are very non-compliant with medications. And so in order to reduce the, pill burden in introducing like phosphate inhibitors and iron in these patients who are not dialysis dependent, we are using ferric citrate. The brand name here is Orexia. We feel that it doesn't get the same potency in terms of phosphate binding as many of our other drugs, especially our time tested and true calcium containing antagonists. But I think there's something to be said about the dose relationship as well. So, but it's still being worked out. We are definitely using it, and I think I can say that in our patient population, it's very well tolerated. So, which was the big thing actually. And the pills are not as large as the 7-lemma pills, and so patients are much more likely to take it. So we'll see what our trials show in terms of its effect on phosphate binding as well as keeping up iron saturations.
Okay. And the next question is to Dr. Nivedita. To prove aluminum toxicity, do you do a bone biopsy?
So you don't need to do a bone biopsy to prove aluminum toxicity. If you suspect aluminum toxicity, you could measure aluminum levels. The most common way of getting aluminum toxicity is from your water in patients on dialysis, hemodialysis. So checking the water quality, I think, is an important way to assess the probable risk of aluminum. A bone biopsy could also be done, but it's a very invasive procedure. So you could look at aluminum levels itself. You could look at risk factors. Aluminum containing phosphate binders, of course, are no longer used. One of the other modalities by which they may get is from the water sources itself. So those are all the ways in which you could look at it.
Next question is there any, Dechu ma'am, like I just wanted to know, do you proceed with bone biopsy for proving aluminum toxicity?
Not at all. Not at all. No,
all.
we don't. We actually, we periodically check aluminum levels, especially in patients who have erythropoietin unresponsiveness or hyporesponsiveness. We do check like carnitine levels and aluminum levels. And if their aluminum levels are high, we go to see what actually has caused it. I don't know if bone biopsy will add more. Of course, it will show sort of adynamic bone disease, but that you can tell by either looking at your aluminum levels, and proving that instead of doing a bone biopsy. We don't typically do a bone biopsy.
Okay. So the next question is to Dr. Dechu. Is there any target serum iron levels before starting ESA, erythropoietin? I think the question has already been, the answer has already been discussed. Would you like to answer again, ma'am?
We look at ferritin and transferrin saturation. The serum ferritin is a very tricky, thing to look at because it can be quite elevated in inflammation, especially. So, we typically don't, give IV iron if the serum ferritin is over 800. But other than that, if the serum ferritin is over 100, we will start erythropoietin stimulating agents. So yes, it should be at least over 100. And the T-sats for sure is what we look at, and that needs to be over 20%.
Okay. So next question is to Dr. Nivedita. What is the dose of cholecalciferol?
That's the $1 million question, I guess. That's a very, probably a very difficult question to answer because there is no evidence, at least in pediatric literature, to say anything. So the different guidelines mention different things. What I would probably say is that so the ESPN guidelines recommend that you have a maintenance in an intensive phase where you give higher doses, and this depends on the age, in infancy, in younger children and older children. And then you keep a maintenance phase so that you maintain the levels of cholecalciferol. So it is important to have an intensive phase to achieve normal levels and then maintain it over a period of time using maintenance levels and periodically checking for vitamin D. The KDIGO guidelines, or rather the older KDOKI guidelines, also mention that you could use ergocalciferol, as 50,000 international units weekly, or once in 15 days, or once a month, or once in 3 months. So depending on the vitamin D levels. So if you look at studies in CKD, they are very varied. Some are based on the stage of CKD, some are based on the vitamin D levels. The actual levels that you need to achieve are also different based on different bodies that are giving these guidelines. However, for most practical purposes, I think in CKD we accept 30 nanogram per ml or 75 nanomoles per liter as the cutoff level that we would like to achieve. So the main concept is, I think, to give an intensive phase and then keep a maintenance phase to maintain the levels. And the other important concept to understand is not to give very high bolus doses. I think that is definitely phased out completely, especially in children with CKD. So no bolus dose. Other than that, I think whichever preparation is available to you, whatever you think is convenient, keeping in mind patient compliance and availability and follow-up, that kind of regimen could be used. So different regimes are available.
Is ergocalciferol commonly used in CKD?
So if you look at the guidelines, most of the guidelines, at least the older guidelines, the KDIGO, and all, mention ergocalciferol. In fact, there are a lot of studies, even the studies of CKD, children with CKD, is on ergocalciferol. I think Dr. Dechu probably would be able to add more to this, but I think ergocalciferol is easily available in Europe and America, whereas in India it is not available. So we rely more on cholecalciferol. The recent ESPN guidelines that I mentioned in my slide also talks about using either ergocalciferol or cholecalciferol, and also mentions the dose that you could use. Dr. Dechu, would you like to add something on this?
So yes. I mean, we get both forms of, calciferol, both ergo and cholecalciferol, and where we can, we try to use ergo. But we are limited by what insurance will let us use. So that's a big difference between there and here. And insurance will always make us use something that's cheaper and in their formulary. So and many times we just push to a corner using just cholecalciferol. But overall, I feel that they are not hugely different. So we don't fight with insurance companies to cover the calciferol. If they say chola is what is covered, we will just give that to patients. So that's where we are with that.
Okay, ma'am. Next question is to Dr. Nivedita. What point should we consider to use sevelamer?
So the goal here would be to maintain phosphate levels to age appropriate within the upper limit of normal that is acceptable for the age of the child. And you have to make sure that the calcium is at least normal, because if the calcium is low, again, based on the age appropriate cutoffs, if the calcium is low, then it would be preferable to use a calcium-based phosphate binder. If the calcium is normal or high, then probably in that situation, you would consider using sevelamer.
Okay, fine.
Sorry, do you get sevelamer in granules there, or is it only in a pill form?
We get both. We get both
forms.
Okay, great.
Yes.
The next question is, in children with CKD with high uric acid levels, do you routinely use allopurinol? Safety of febuxostat and rasburicase in such situations to lower uric acid. What cutoff of serum uric acid to be considered to initiate?
I can take a stab on that question. So we haven't used rasburicase in patients with CKD. The times that we've used rasburicase is only when you're suspecting a huge uric acid burden, as in tumor lysis syndrome and such. But just hyperuric acid levels in patients with CKD, we've been typically using only allopurinol, not even febuxostat. And our typical cutoff is 10, even though literature says that anywhere above 8, you could potentially consider starting allopurinol. We usually wait for a year. We do, of course, I'm sure you know, we do all the other dietary manipulations in order to, reduce high uric acid levels, because knowing that high uric acid level also accelerates progression to ESRD, we try to do dietary manipulations, which is actually in this country huge, because the protein load, of all of the foods that the children eat is just very, very high. So we try to do dietary manipulation. And then after that, if the uric acid is still going up, which happens in some of our kids with CKD, especially in our African-American kids for some reason, we start them on allopurinol.
Okay. Is there any dialysis specific modification for high uric acid levels, Dr. Dechu?
Not to my knowledge, because we use high flux dialyzers in all our patients, and so we don't specifically make any modifications for for patients with high uric acid. I don't know. Is there anything that you all do in India?
No, actually, we use. Yeah, proceed, ma'am. Nivedita.
Yeah. So just to add to what Dr. Dechu is saying, that we do not use any specific dialysis modalities for sure, but also we don't use allopurinol regularly. There is evidence in adults to show that febuxostat is safe, and you might have seen a lot of adults who are on febuxostat. As far as I know, there aren't any studies recommending it in children, and we don't have any experience of using it either.
Okay, fine, ma'am. Next is we are not screening for primary hyperoxaluria. As you have mentioned, CKD in a 6 months old child, which clinical features should suggest us to think of primary hyperoxaluria?
So primary hyperoxaluria is one of the important, if you're looking at an infant with CKD or ESRD, then one of your differential diagnoses that you have to keep in mind is primary hyperoxaluria, because it is, especially PH1, can occur very early in infancy. The other important factor that we look at is the presence of multiple calculi, significant nephrocalcinosis, the kidney being studded with nephrocalcinosis, or family history of having had in the previous siblings. All these would be clinical pointers that may tell you to, push you towards a primary hyperoxaluria in an infant with CKD or ESRD.
Yes. The next question is there any radiological difference between rickets and renal osteodystrophy?
So rickets is a clinical manifestation of abnormal mineralization of the bone, and is typically, described in children who have a growing bone, with the adult counterpart being osteomalacia. So it's a defect in mineralization of the bone. The bone volume and turnover, like we said, that is how the bone is assessed when a bone biopsy is done. So that would have a normal volume and turnover, but a abnormal mineralization. Whereas renal osteodystrophy is typically where there is a hyperparathyroidism and a high turnover. So that is the characteristic feature. Mineralization may be normal, may not be normal, but the typical, the characteristic feature is that there is an abnormal turnover. So this is the basic difference between the two.
Okay, fine, ma'am. Anything to add on, Dechu, ma'am?
Well, I think radiologically, the features are, you cannot distinguish rickets from renal osteodystrophy. One of the things that I tell residents when I teach is that if you know all the features of rickets on an X-ray, those are the same or the similar features on an X-ray of renal osteodystrophy as well. So radiologically, it's difficult to distinguish, but I agree with Dr. Nivedita, you know, it's all a matter of bone turnover. And so that's something that needs to be kept in mind. But when you look at an X-ray, I don't think it's hard. I don't think there is an easy way of distinguishing one from the other, unless you have a history.
Next question is on what is the most common cause of bilateral renal calcification in infants or toddler with CKD in your experience? To Dr. Dechu.
Yeah. I think as you know, one of the most common ones is, like Dr. Nivedita alluded to, is hyperoxaluria. But we also see significant amount of nephrocalcinosis in our you know, premature babies who've been treated with Lasix or with, you know, loop diuretics, furosemide. That is one of actually the most common you know, time that we see bilateral nephrocalcinosis in our kids.
Okay. The next question is how far it is useful to use cholecalciferol or ergocalciferol in CKD? I think the question is already answered.
Yeah. Yeah.
Is there any difference in the potency of cholecalciferol and ergocalciferol in CKD, ma'am? Dr. Dechu?
Well, you know, I mean, it is touted to have, you know, a little more potency with the ergocalciferol compared to chole, but we've used it, you know, with no difference at all when we give these dosages. I don't know if there are any comparable studies to say one is supremely better than the other, except for a few minor differences. I don't know, Dr. Nivedita?
Yeah, I agree with you completely. I don't think there is much evidence to show that one is better than the other. And I think, like you just said, it's what is available to you and what is, as long as you maintain the levels and use what is feasible and available.
Yeah.
Okay. The next question is to Dr. Nivedita, like dose of active vitamin D, that Rocaltrol for hyperparathyroidism in CKD.
So 10 to 20 nanogram per kg per day is the recommended dose, and generally, I mean, it could be given as a twice weekly or a thrice weekly initially, and depending on the calcium and phosphate levels, you could, and of course the PTH levels as well, you could titrate it. So that is how you would start off with calcitriol.
Okay. The next question is to Dr. Dechu. If blood transfusion is being given, when is the ideal time to do iron saturation or ferritin levels?
Oh, okay. So what you're saying is once you give a blood transfusion, you can have higher iron and ferritin levels. And so how long after a blood transfusion should you be checking that, right? Ideally, we would check it. Ideally, we would check it 4 to 6 weeks post blood transfusion. By then, you would have had stabilization. But most of the times, you see that, you know, there's a prolonged improvement in iron levels following a blood transfusion. But we would check it in 4 to 6 weeks only to make sure that if the PSATs are actually falling, then we would be starting iron therapy much sooner rather than later. That's when we would do it. Does that answer the question?
Yeah, yes, ma'am. So the next question is choice of antihypertensives to start and further add-ons. Which patient would you consider ACE inhibitors, ARBs as per GFR?
Yeah, so I don't know. I don't know if you wanted to take that question, but I can take the first shot at it. So basically, if there is protein, it's all about risk benefits at this point. You know, I don't think there's a sort of a cutoff as to when you would start or stop ACE inhibitor therapy. I think the important thing is if a patient has proteinuria, knowing that proteinuria can also accelerate, you know, the development of ESRD, we would put them on ACE or ARB. You know, also knowing that the ACE or ARBs can increase your creatinine or decrease your GFR by about 10 to 20%. So 20% is sort of our cutoff in terms of, you know, the decrease in GFR that we would tolerate when we use ACE or ARB. If we find that there is a significant decrease in your GFR, then we would hold off on giving the ACE or the ARB. Another thing to consider is if the patient's GFR is less than 30 and the patient is really close to needing dialysis, we would definitely hold off ACE or ARB, because that would tip this patient over the edge and put them into dialysis, especially with the significant decrease in GFR. We don't hold ACE or ARB for anemia, even though we know that ACE or ARBs can be inhibiting erythropoiesis. We usually adjust our ESA dosages in order to combat anemia and not take them off ACE or ARB. Also because, with ACE or ARB, you have a good control of, fair control of proteinuria and also hypertension. So, it does more good than it does harm. So we keep them on ACE inhibitors if they have proteinuria and hypertension, even though their anemia may be a little more difficult to control, and even though their GFR may be slightly low. But again, like I said, our threshold to stop ACE or ARB, if there's more than 10% decline in your GFR, or if they're close to requiring dialysis.
Dialysis. Okay, fine. The last question is to Dr. Nivedita. Does vitamin D analog causes pseudotumor cerebri? Dr. Nivedita, you're there?
Yes, but I can't hear you very clearly.
Okay, does vitamin D analog cause pseudotumor cerebri on long-term use?
Can you hear me?
Yeah, we are able to hear you, ma'am.
I'm sorry, I couldn't hear the question. Could you repeat?
Does vitamin D analog cause
vitamin D
tumor cerebri on long-term usage?
I'm sorry, Dr. Kalai, I couldn't hear you. Long-term usage of?
Does vitamin D analog causes pseudotumor cerebri on long-term usage?
Vitamin D, is it? So hypervitaminosis, one of the features of hypervitaminosis is known to be pseudotumor cerebri is known to be one of the features of hypervitaminosis. But you need to monitor the levels of vitamin D regularly when a patient is on a vitamin D, and you need to stop the drug. Like your goal of therapy would be 30 nanogram per ml, but if it's exceeding 75 or 100, definitely you need to stop the drug. But most of the studies that have show clinical manifestations only above 250, but we are not even looking at that target. So above 100 nanogram per ml, we would probably stop the drug.
Okay. I think there are a few other questions, but I think it's not relevant to this topic. We might be answering these questions when the topic is on. Thank you so much. Thank you, everyone. We had a very excellent discussion on anemia, on mineral bone disease. It was a very fruitful discussion. Thank you so much. I think we can close the session, and we are running short of time. We have exceeded our time as well.
Thank you for including me in the sessions. Thank you so much.
Thank you, Dr. Dechu. Thank you, Dr. Nivedita. Thank you, ma'am.
Thank you very much. Thank you for this opportunity. And yeah,